It. The recording is in progress. Okay. So for those of you who have not attended before, I am Maria Markowitz from the Georgia Cancer Center, and I'm part of the hub team of our teledermatology serving Georgia program. And along with Dr. Doug Patton, I will be co-facilitating this session. So we do like for people to put their cameras, turn their cameras on in gallery view as much as you can when we aren't screen sharing, so that we can see each other as we are discussing. So let's see, can we have the slides? Okay, so I want to remind you all of our website, which, yes, okay. So we are having problems here. What's going on? Okay, so here we are, our teledermatology serving Georgia webpage. There's a lot of good information on our website. So I urge you to take a look at some point. We have training videos on dermoscopy and dermatology, and some of those you can look at and get CME credit by logging in the right way, following the directions. And then we also have YouTube's recordings of most of our past TeleECHO sessions, except for we apologize that the last 5 or 6 hadn't gotten posted, but we're in the process of getting those posted now. So when you have a few minutes, take a look at our website. So I want to welcome all of our participants today. So we know some of you are PCPs from rural healthcare centers that participated in our previous clinical project, which was funded by the USDA, and have been coming for all 31 of our TeleECHO sessions. And others are clinicians from the East Georgia healthcare centers who are now participating in phase 2 of our program. And I know we have residents and perhaps faculty from the MCG Family and Community Medicine residency program, and who are also, the residents are also participating in phase 2 of our program. We have faculty from our MCG Department of Dermatology. So Dr. Loretta Davis is here, Dr. Kendall Buchanan. I did not see Dr. Rabinovitz log on yet, but hopefully he will be here. And then I suspect we have some MCG medical students, former students and newer students. And then, of course, we have our Georgia Cancer Center TeleDerm hub team handling the controls, Brenda Santiano and Kenza Mamuni. And we certainly could not run these TeleECHO sessions without them. I am very dependent on them, for sure. And so are you. So, and we may have other prior other participants. We have had people from around the globe. I'm not sure if they're on now, but, and then I suspect we have some people who are attending for the first time. So we welcome you all to today's session. So for those of you who are used to coming, remember, please, to put in the chat your name, your clinic affiliation, where you are, and what your position or what your title is, and also your email address. We need all of that for our records, and I think there are a lot of those already put in there. So we can review today's agenda for today. So we are starting the first of a series of 3 lectures, which both the didactic and the case presentations will be done by our new friend, Dr. Vinnie Seiberling. And I'm going to just give you a little background about Dr. Seiberling. She is an associate professor from the Department of Dermatology at Tufts University School of Medicine. She received her MD degree from Penn State College of Medicine. She trained at Mass General Hospital and did residency in dermatology at University of California in San Francisco. And she was the dermatology division director for the Maine Medical Center, Maine meaning the state of Maine, and the medical director for the Maine, state of Maine, Medical Partner Skin Oncology Clinic. She has a special interest in non-invasive tools for the detection of skin cancer, such as dermoscopy, and has developed multiple dermoscopy curricula and served on the American Academy of Dermatology Basic Dermatology Curriculum Work Group, which aimed to put dermoscopy as part of the standard medical school education. And she has worked passionately to improve access to dermatology care in rural settings, both through Project ECHO sessions and teledermoscopy with e-consults. And in this past year, in addition to her role at Tufts University, Dr. Seiberling became the director of teledermatology for the national nonprofit Rural Access to Dermatology Society, known as RADS. And she firmly believes that all patients deserve high quality dermatologic care, regardless of their geographic location, which is one of a big mission of us here at the Georgia Cancer Center. And so we are really lucky to have Dr. Seiberling visit us for our series of 3 TeleECHO sessions. And now, speaking of passion for rural access to care, I will introduce you to Dr. Doug Patton, who will take over today's session. So Dr. Patton is the Dean of the Southwest Georgia Regional Campus of the Medical College of Georgia, and he spent most of his career as a rural physician. So take it away, Doug.
Thank you so much, Rhea. It's good to be here today, and it's good to be embarking on what we hope is going to be a very productive and engaging series of programs for us, which turns out to be just kind of a start of what something even bigger and greater could be coming in the future. But I'm going to save that for Dr. Seiberling to share with us later. So as we go forward, we'll have the next slide, please, and we'll just talk a little bit about our normal rules here for this. And this is a reminder that Project ECHO is a global project that is dedicated to moving knowledge instead of people, bringing the information to where you are and allowing you to be a participant in the educational process for all of us involved. Extension for Community Healthcare Outcomes is what it stands for. Next slide, please. So these sessions are meant to improve knowledge, particularly in this series for teledermoscopy and teledermatology, to help you at the local level use these distance learning approaches so that you can provide better care for your patients where you are, knowing that folks in rural areas, particularly in parts of our state, have a very difficult time obtaining access to specialized care. Next slide, please. So these again are recorded, as we know from all of our things, and that by simply remaining online, you're consenting to being recorded. It's a reminder also that these are not consultative sessions. They're educational only, so please do not mention PHI in the discussions. These are not protected for those purposes. There will be information about continuing education credits at the very end of the presentation. And of course, you can email to teledermatology@augusta.edu at any time along the way, but you can also put questions or concerns in the chat. If you're having technical difficulties or anything like that, please do that right away. Next slide, please. So we do collect data. This is just a reminder that from registration all the way through post evaluations, including reviews and things like that afterwards. This helps us not only to understand whether we're delivering value, but also to plan for future programming to meet your needs. Next slide, please. Just general Zoom reminders, mute and unmute based on whether you need to be heard or not heard, or whether you got leaf blowers blowing outside your windows or not. And by the way, Rhea, I wasn't able to hear those, but my wife says I can't hear anyway. So
Oh, they're done. They've stopped now. So
okay. Good. An answer to prayer, no doubt. So you can always again type questions into the chat, raise your electronic hand, as we know from the buttons on the bottom down there, whether you go to the icon. And please keep your camera on if your bandwidth will support that, so that we can see you throughout the presentations. And also, if you need to get our attention, you can with your camera on, we can see if you need to wave at us. Again, the contact information for Kenza is there for technical problems. Again, the chat is always available. Next slide, please. And with that, it's my pleasure to introduce Dr. Vinnie Sieverling. Again, as you heard the introduction earlier, we're delighted to have her join us. She also has a young colleague with us that I will leave for her to introduce because young Raphael is here to help, and I'm sure we'll have wonderful things to contribute. Dr. Sieverling, welcome to the session, and we're grateful to have you here. I'm going to turn it over to you.
Thank you all so very much. I am thrilled. Let me make sure I have. Yes, you can see my slides?
We can see your slides. Thank you.
Okay, fantastic. I am going to annoyingly put that survey in the chat one more time. So thank you all so much for the opportunity to speak today. It sounds like we have many aligned goals. My topic today is skin cancer and a dermoscopy introduction. My only disclosure for this presentation is the fact that I consult for an e-consult company, and this is actually a collaborative effort, as was mentioned. I work for the Rural Access Dermatology Society called RADS, and this is a presentation in partnership between RADS and the Georgia Cancer Society, or Georgia Cancer Center. So RADS is a nonprofit that was mentioned, and our overarching goal is to improve access to care for patients with skin disease in rural America. The way we want to do that is to empower primary care practitioners to feel comfortable diagnosing and managing skin disease. So we put together a series of virtual programs, and I'm going to come on site to many of your clinics to work on being able to recognize and identify some of the most common dermatologic conditions that our patients will encounter. To be able to continue offering these type of outreach endeavors, if you could please complete the survey. I understand that you do a lot of surveys. It's very short, it's very brief, and if you happen to not be able to attend one of the Georgia Echoes, we welcome you to any of the other national offerings that are part of the survey. All right. Without further ado, we're going to talk about skin cancer, dermoscopy, and all of the important roles that we as dermatologists and you as primary care practitioners or medical students play in the diagnosis of skin disease. Skin disease and skin cancer are incredibly common. In fact, in the United States, there are 3.5 million new skin cancers diagnosed every year. That accounts for more cancer diagnoses than prostate cancer, breast cancer, lung cancer, and colorectal cancer combined. Now, fortunately, most of these skin cancers are actually basal cell or squamous cell carcinoma, which do not carry significant mortality risk. But of these 3.5 million new cancers, there are 200,000 new melanomas diagnosed each year in the United States, half of which are invasive, and there are 10,000 melanoma-related deaths on average in the US. Unfortunately, these numbers are expected to continue to worsen due to the deleterious effects of climate change. By 2050, it is already expected that we will have a 10% increase in the incidence of skin cancer in the United States. When you think about the magnitude of this issue, 25% of phototype 1 or 2 or very fair skinned patients already get basal cell carcinoma. When we look by 2050, over a third of that patient population will be developing skin cancer. Fortunately, all types of skin cancer are curable when they're detected early. In fact, even melanoma is detected early, and stage 0, the 5-year survival is about 99%. But unfortunately, like this stage 3 melanoma, if it is detected later, the 5-year survival is significantly lower. Now, the majority of the mortality associated with skin cancer is linked to melanoma, but there's a significant amount of morbidity linked to basal cell and squamous cell. This is a patient of mine. He was uninsured for many years, and then he sought care at a federally qualified health center. And this was too advanced for local management, and he did end up having an amputation due to this. Our hopes are that we can detect these skin cancers far earlier, and then the treatments are much less morbid. Being able to detect skin cancer early requires access to care. This map shows the geographic distribution of dermatologists across the United States. All the areas in gray are areas without a single dermatologist. If a patient is diagnosed with a melanoma and they live in a county without a dermatologist, they are far more likely to die from the disease. If they live at a greater distance from an academic medical center, they're more likely to have poor outcomes related to their melanoma care. And unfortunately, many of these areas without a single dermatologist are also areas with very high rates of melanoma. For instance, where I practiced for 4 years in rural Maine, there are very high rates of melanoma, as are in Georgia. So we have a real issue. Lots of patients with melanoma, very few dermatologists. And because of this, the burden of identifying and determining whether a growth is worrisome for skin cancer or not typically falls in the hands of primary care practitioners. In fact, up to 25% of what is seen in the primary care office is for something related to the skin. It's not always a growth, because we also recognize that rashes present to primary care. But the vast majority of worrisome skin growths present first in the not to the dermatologist, but to the primary care doctor. And a lot of times our colleagues in primary care do not feel comfortable making that important triage decision. In fact, when I was at Maine Medical Center, we did a needs assessment, and we found that only about 10% of my primary care colleagues felt comfortable using a dermatoscope to evaluate a skin growth, and only about half were doing skin biopsies. This aligns with the national publications showing that most primary care practitioners desire more training on skin growths, biopsy techniques, and the American Academy of Family Medicine family practice now includes dermoscopy as a core competency in their recommendations for all family medicine residents. So, with this in mind, we want to promote access to care by empowering primary care practitioners to evaluate skin growth using dermoscopy. And so I want to start by looking at different types of skin cancer, and we're going to add in what they look like under dermoscopy. The 3 most common types of skin cancer are basal cell, squamous cell, and melanoma. The basal cells emit from this cuboidal layer at the bottom of the top layer, if you will. So here's the epidermis. Here's the dermis, and here's the fat. The basal cells live at the bottom of the epidermis. Amongst the basal cells are the melanocytes. They have these dendritic proliferations and projections that come out from the edge and shoot melanin up into the squamous cells, which are also called the keratinocytes. When we think about who is affected by skin cancer, it's truly everyone. All patients are at risk of developing skin cancer independent of their phototype, but the way that it presents in different Fitzpatrick skin types is different, meaning phototype 1 and 2 patients are more likely to have basal cell carcinomas on sun-exposed sites, but phototype 5 and 6 patients are less likely to have basal cell, and we need to be more worried about squamous cell carcinoma or even acral lentiginous melanoma. So during this presentation, I'll focus on the phototype, and we'll look at skin cancer across the phototype spectrum. First of all, basal cell carcinoma is the most commonly diagnosed skin cancer in the United States. It affects sun-damaged skin and is most common in our fair-skinned patients, meaning phototype 1, 2, or 3. It presents as a non-healing, often ulcerated growth on sun-damaged skin. Because we drive on the left side of the car in the United States, there are more skin cancers on the left cheek and the left side of the nose, as opposed to in Australia, where this is reversed. Most of the time, basal cell presents as this non-healing growth with a shiny or rolled border. One of the take-home messages of this presentation, and what I always tell my residents, is if you see a patient over 50 and they have a non-healing growth on sun-damaged skin, that is a skin cancer until proven otherwise. If a patient has a bug bite or a nick shaving or some kind of trauma to the area, it should heal within 2 to 4 weeks. But if it doesn't heal and it keeps getting larger, we need to worry about skin cancer. Over time, basal cells grow and they start to erode, but they very rarely metastasize. The ideal diagnosis would occur at this stage on the left, not when it gets larger and more eroded. But detecting skin cancer at its earliest stage requires the use of dermoscopy. Dermoscopy allows us to see below the surface of the skin, and we can see colors and structures that are not visible with the naked eye. And we can better appreciate things like telangiectatic or arborizing vessels. We can see areas of invasion, which are represented by shiny white structures. And we can see highly specific features like blue-gray ovoid nests and leaf-like structures, which often have over 96% specificity for basal cell. So what is dermoscopy? Well, this is a dermatoscope. It's 10x in vivo magnification. It is a non-invasive way to get a better look at the skin. When you put it on the surface of the skin, not only can you see surface structures, but you can see deeper down into the dermis. And when it is used in trained hands, it reduces the number of biopsies to detect a malignancy. Sometimes, with the naked eye alone, it can be very difficult to know what category of growth something is in. For instance, on this 72-year-old man, he has a non healing preauricular multicolored growth. The differential diagnosis might include a seborrheic keratosis that's traumatized, a melanoma, or even a basal cell carcinoma. But with dermoscopy, it's immediately obvious. Here we see a neovascularization. This is a large telangiectatic vessel. We see shiny white blotches and strands and blue-gray ovoid nests. These are all characteristic of basal cell carcinoma. When you use dermoscopy, the first light that comes on is polarized light. Polarized light allows us to look into the second layer of the skin, the dermis. I think of it like my polarized sunglasses. If I have polarized sunglasses on and I look at a koi pond, I'm able to see the colors and structures much more easily. And I get a deeper, richer understanding of what's happening just below the surface. Overwhelmingly, what dermoscopy does is it helps us categorize growths. Sometimes with the naked eye, it's hard to know whether something's vascular or keratinocytic. And if we're in the melanocytic category, it much better helps us differentiate a benign melanocytic growth from a potential melanoma. Back to basal cell. This is a shiny, pearly, non-healing growth on sun-damaged skin in an 82-year-old man. When we use our dermatoscope, in addition to seeing that little superficial vessel, we see all kinds of other things. We see arborizing, tree-like vessels, shiny white blotches and strands, which are a sign of invasion. We also see areas of ulceration and blue-gray ovoid nests. This helps us confirm our clinical suspicion that this is indeed a basal cell. Now, the gold standard for diagnosing skin cancer is still histology. Once we've seen clinical and dermoscopic features that are worrisome for skin cancer, a shave or tangential biopsy is what's recommended for the vast majority of growths that are worrisome for basal cell. This is performed using a dermablade or a scalpel. This is the same technique that is typically done for squamous cell carcinoma, or if something is benign but bothersome, the dermablade can also be used to remove inflamed seborrheic keratoses or nevi if needed. The one thing to know about shave biopsies is you want to practice your depth, because you can actually remove quite a lot of skin or accidentally transect very high up and not get an adequate sample. Once the basal cell is diagnosed, then we want to make sure that we guide the patient through the management process. So one thing that's important to recognize is that if you're going to be doing skin biopsies, then you want to feel comfortable interpreting the pathology and guiding the patient on what the next best management strategy is. And the same treatment isn't really used for all patients. Some patients in their 80s who have a low risk basal cell, like a superficial or nodular basal cell, might not want aggressive surgery like Mohs micrographic surgery. Some of them might, but it's important to recognize the full spectrum of treatment options. Some of our patients want to be reassured that they don't have a life-threatening growth like a melanoma, and then based on that information, they will decide which of these modalities with your guidance is best for them. In this situation, this patient actually had advanced Parkinson's disease and wanted a less aggressive approach. There is some literature to support more of a palliative, watchful waiting approach because basal cell carcinomas grow slowly. Now, we obviously recognize that the cure rate of watchful waiting is 0%, in contrast with Mohs micrographic surgery, which is surgical approach, is 99%. But I just want you to be aware, especially for the medical students, that aggressive treatments are not necessary for all of our patients. This patient actually passed away 3 months after this picture was taken due to complications from his Parkinson's disease. And so the watchful, more palliative approach was appropriate in his case. And there is now a care assessment need score that was published through the VA in California, helping us quantify the 1, 3, and 5 year risk of mortality for our patients. Because, of course, we don't have a crystal ball, and we want to take really mindful approach as we counsel patients about how to manage and approach basal cell treatment. All right. Moving on from basal cell, squamous cell carcinoma. Squamous cell carcinoma is the second most common type of skin cancer, and it does occur in non-sun exposed areas sometimes, and that is typically linked with an HPV infection, especially when it occurs on genital skin. But the vast majority of squamous cells present on sun-damaged skin, for instance, on the scalp, and they're often tender and crateriform and quite scaly. Other areas that are often affected by squamous cell carcinoma are the ears or the lips or the dorsal hands. Just like patients who smoke can get squamous cell carcinoma of the lung, squamous cell carcinoma of the skin is at an increased likelihood in our patients who smoke. Unlike basal cell, squamous cell carcinoma does have a risk of spreading to the lymph nodes at a higher likelihood than basal cell carcinoma. If it spreads to that lymphoregional basin, it can be much more difficult to treat and require systemic therapy. In certain situations, more aggressive squamous cell carcinomas are more common. For instance, in the setting of areas of recurrent inflammation like discoid lupus or areas of poor venous return, more aggressive squamous cells are more common. So this is a phototype 5 patient who has a large squamous cell carcinoma in the setting of her discoid lupus. This is a patient of mine who has squamous cell carcinoma that has spread to the lymph node. The precursor to squamous cell carcinoma are actinic keratoses. These are superficial pre-malignant growths, some of which will go on and become squamous cell carcinoma. Oftentimes, they present as a rough, gritty area on sun-exposed skin, and here we can see before and right after cryotherapy was performed. These differ from invasive squamous cell carcinomas because upon palpation, these are not usually tender and they don't have an indurated base. One thing to keep in mind is when you see one, there are often others in that vicinity. So here's yet another actinic keratosis on the preauricular ear. Dermoscopically, basal cells and actinic keratoses have different features. The most important thing to recognize is that actinic keratoses and squamous cell carcinomas are keratinocytic proliferations of the top layer of the skin, and therefore the vast majority of them will be scaly. Before you apply your dermatoscope to the skin, if you use a liquid medium like I do, you want to look for scale because that liquid medium can sometimes wipe away the most important diagnostic clue, which is the scale. Once you've looked for the scale, then you can look for other fun features, one of which is called the strawberry pattern. This is where you have a combination of pink, red, and white. All of these white areas are called rosettes. Rosettes represent scale in the follicular or hair follicle opening, and they're oftentimes ubiquitous or numerous in actinic keratoses. Now, I'll tell you, they're not specific to actinic keratoses. In fact, Dr. Buchanan, who is a dermatologist with you, and I looked at the incidence of actinic keratoses and other conditions that can have it. And there are actually 47 other diagnoses that can have actinic keratoses. So the point of recognizing that is that actinic keratoses can have this fun rosette feature, but it is sensitive to that, not specific. As tumors keep progressing from an actinic keratosis into a squamous cell, neovascularization will occur. You'll see lots of blood vessels under dermoscopy. You'll even see white circles. So these are dilated follicular openings representing a keratinocytic proliferation. The other thing to recognize is that squamous cell carcinomas grow really fast. They grow much faster than basal cell. In fact, this preauricular squamous cell grew within 1 month. It was tender, indurated, and raised. And under dermoscopy, it has scale, dilated white circles, it has a few rosettes, and it has signs of neovascularization. Just like basal cell, squamous cell carcinoma is also confirmed with a skin biopsy, typically a shave biopsy. Now, in this situation, we want to make sure that we're getting under the epidermis, because if we transect the epidermis, the pathologist won't be able to tell us whether this is an in situ tumor, if it's an invasive tumor, or if it's just an actinic keratosis. So if you see something, especially if it has an indurated base, you want to get under that with your dermablade. All right. Management of squamous cell carcinoma depends a bit on the features that are reported histologically. If a tumor is very thick, or if it has perineural invasion, or it's on a special site like the lip or the genitals, then we're going to need to be more aggressive and often use Mohs micrographic surgery. There are other conditions or considerations, which is how big is the tumor? Meaning, is it in breadth greater than 2 centimeters? What is the age of the patient? Are they immunosuppressed? Are renal transplant patients often don't respond if they're immunosuppressed to topical modalities like 5-fluorouracil or a imiquimod cream, which rely on eliciting an immune response. And so these comorbidities weigh heavily into the decision making for squamous cell carcinoma patients. In summary, most of the time, actinic keratoses are treated with cryotherapy, which is what we can see here, and most invasive squamous cell carcinomas are treated with excision or Mohs micrographic surgery. Here's an example of that decision making. This is a high risk location. This patient has a squamous cell carcinoma on his nose. This is not a good choice for a less invasive procedure because of the size and the location. In contrast, on the left cheek of this patient, this is pretty localized growth, and this is quite amenable to a standard excision with a 4-millimeter margin. When we put this all together, the patient presents to the primary care office with this tender, indurated growth. The first thing we do is pull out our dermatoscope, take a look. We see, lots of vessels, scale, crateriform area in the center, worrisome for skin cancer. Step 1 is a shave biopsy. When we do the shave biopsy, we've got invasive squamous cell carcinoma. Step 2 is to work with either the surgeon at your site, or some family physicians also do these excisions in their own clinic. And that's to do a 4-millimeter margin around it using an elliptical excision and making sure that the margins are clear. All right, lastly, and I promise we'll have time for questions and cases, is melanoma. The incidence of melanoma is on the rise in the United States and across the world. It used to be about 1% of the population, and those numbers are now up to about 2% of the population. Now, the way melanoma presents differs depending on the patient's phototype. If the patient has phototype 1, 2, or 3 skin, meaning they burn more easily when exposed to the sun, the number one site for these patients for melanoma in men is the back, and women is the lower leg. In phototype 5 and 6 patients, the presentation is different. It is often on non-sun exposed skin, like the plantar aspect of the foot or even subungual under the nail. One of the risk factors for developing melanoma is a single blistering burn in childhood or adolescence. This significantly increases the risk of developing melanoma in that patient's lifetime. Another risk factor is the use of tanning beds. Tanning beds have been linked to the association of melanoma as a leading cause of cancer death in women 25 to 30. So it's very helpful if you're doing your well child visits in a 14, 15, 16-year-old girl, make sure that she's not going to the tanning bed on a regular basis because that has been linked to a significant increased risk of melanoma. Melanoma often presents on the skin as the outlier. It doesn't look like the other growths on the body. It can be multicolored or regularly shaped, or it can be pink and eroded or ulcerated. All types of melanoma are easier to diagnose when you're using a dermatoscope. Overarching goal with melanoma care and is early detection. If we catch a melanoma when it is confined to the epidermis, the likelihood of that patient having lymph node involvement is nearly zero, making their 5-year survival almost 99 to 100%. The most common type of melanoma is superficial spreading melanoma. This is what the ABCDEs of melanoma have been described for years. Asymmetry, border irregularity, multiple colors, and in my opinion, the most important one is evolution. Non-cancerous things don't tend to keep getting bigger and larger and taking on more colors. In addition, most non-cancerous things have friends, meaning they have other growths in the area that look like them, whereas melanoma tends to be the clinical outlier. This is a case of a nodular melanoma. So nodular melanomas are not as common as superficial spreading, but they're associated with a rapid vertical growth phase. The reason I share this case is that this patient had actually been to 5 different practitioners in the month before he came to see me. This patient was recently seen by peripheral vascular surgeons and had stents placed. When he had the stents placed in his lower leg, they put him on clopidogrel, a blood thinner. And then the tumor on his arm started to grow and bleed. This is a large melanoma with what we call the Band-Aid sign. So for all of you in primary care, when a patient has a growth covered up, take that bandage off, take a look, because sometimes there's a large skin cancer underneath. This is a dermoscopy showing the multiple different colors and all of those vessels that are a sign of neoangiogenesis. At the time of presentation, this patient had bulky lymphadenopathy, he had stage 3 disease, and he unfortunately died less than a year after presentation. I think back on this case and I wish that we had recognized it earlier because we could have likely changed the outcome. Next, acromelanoma. Acromelanoma is not one of the most common types when you look at all of the melanomas diagnosed in the United States, but it is common in phototype 4 and 5 and 6 patients. It presents either as a multicolored, irregularly shaped growth on the plantar aspect of the foot or as a non-healing tumor, which is what we see here in the top right. The likelihood of lymph node involvement is higher, especially if the disease is diagnosed later. Lastly, there is a type of melanoma which is called lentigo maligna melanoma. This is melanoma on sun-damaged skin. When you look at patients over 70, if they're phototype 1 or 2, this is the most common type of melanoma you will see. It presents as an ill-defined, multicolored, meaning tan, gray, brown, black growth on sun-exposed skin. This differs from other types of melanoma in that it has more of a radial growth, so it grows very slowly out and is less likely to grow deep. This creates a bit of a management conundrum because these tend to be very large and can be on sun-exposed and facial skin. And so in addition to surgical modalities, sometimes less invasive treatments like imiquimod cream are used to treat these patients. All right, let's come up for air and look at this case. This is a 63-year-old phototype 2 man. He lives in Caribou, Maine. That's 5 hours from where I used to practice. He was referred with no images or anything, just came in because of a question seborrheic keratosis on his abdomen. It was put in routinely, and our next office visit was 4 months later. So he waited 4 months for the visit, and we can see he has an outlier growth. It's multicolored, irregularly shaped, and here it is under dermoscopy. Now, the thing to know about dermoscopy is you got to trust your gut. Sometimes you look at something, you're like, ooh, that looks really ugly. And that is an important thing to pay attention to, because most melanocytic growths that are malignant under dermoscopy have what's called a disorganized appearance, a chaotic distribution of the colors and structures. And that contrasts with what we typically see in non-cancerous melanocytic growths, which is a nice organized appearance. So most melanomas are disorganized under dermoscopy. They have a chaotic distribution of their colors and structures, typically due to the presence of multiple red flags, which include blue-white veil. This is a sign of an invasive process and remodeling deeper down in the dermis. We can also see atypical pigment networks in multiple colors. With the naked eye, we can see many colors, but with dermoscopy, we can see far more colors. Now, the gold standard for diagnosing a melanoma is still the histology, and we need that information to stage the patient. The preferred way to biopsy a potential melanoma is an excisional biopsy, but an excisional biopsy can be completed multiple different ways. It can be done using an elliptical excision, but it can also be done doing what's called a scoop or saucerization, where you achieve breadth and depth, meaning you get under the growth such that we aren't transecting the melanoma. The other thing to recognize is that we don't want to do punch biopsies that are just small punches of a large melanocytic growth, because we can achieve sampling error and miss the melanoma entirely. So this is my colleague, my physician assistant at the time. She marked out a 1 to 2 millimeter margin. She angled her dermablade deep down. This takes about 2 minutes to complete. This patient traveled 5 hours one way. We didn't want to have him come back for a second procedure. We did the procedure that day, and then yes, he needed a subsequent melanoma surgery, but we wanted to complete that biopsy that day. And indeed, that was a melanoma. And if you want more tips and tricks on how to perform skin biopsies, I encourage you to look at this article that we wrote a few years ago now on dispelling the myths of skin biopsies. And we look at the kind of perpetuated myths in medical education, sadly, about how if you think something's a melanoma, you need to perform a punch. That's actually not true, because punches sometimes don't give us the information that we need. In the interest of time, though, I'm going to keep moving along, and we can review that article at another meeting. That was a melanoma, and most melanomas need to have a wide local excision, and depending on the thickness of the melanoma, the patient may also need a sentinel lymph node biopsy or other systemic workup. Here's an example of a 42-year-old phototype 1 patient who had a brown macula on his leg for years, and then the pink area presented, and that's the melanoma arising from the nevus. This occurs about 30% of melanomas arise from a pre-existing nevus, and it's important to recognize they aren't all black in color. In fact, melanoma can be pink. And this is what a wide local excision looks like. One thing that many of my patients say is, oh, I've had 5 melanomas, but when you look at their scar, they're only about 1 centimeter long. Most melanoma scars are many centimeters, 6 to 7, 8 centimeters long. And so those patients probably had atypical or dysplastic nevi, whereas most melanomas are very long, and most patients have 1 melanoma, not multiple. So with that, I'm going to open up for questions, and I have a bunch of interactive cases we can go through. And I just want to say thank you to Dr. Buchanan for starting the conversation to have me here with you today.
Well, this is great. We thank you so much for those interesting cases and for the practical tips and tricks that you kind of went along the way. We we've got folks who are signed on, including Dr. Sheldon and many of his colleagues from East Georgia. We've got school-based health centers. We got lots of folks. I'm quite sure someone has a question for you right now. I just don't see anything in the chat.
Well, feel free to unmute yourself. And if not, I actually, to balance out all that scary stuff, I saw some cringe faces when I showed that big melanoma. I brought some benign things for us to feel better about. But any questions before we look at a few cases?
Question. Thank you. It was a really good presentation. And I'll put a plug in that Dr. Sherman will be coming to East Georgia Healthcare Center for our November Provider Meet. And we're really looking forward to you coming down. And it was very, very, very helpful, this presentation. For your shape biopsies, do they typically heal by second intention, or do you have to put a stitch in them? What are your thoughts on
Great
that?
question. So I actually have, it's later in the talk, but I have a picture of the whole tray that we use for our shave biopsies. But yes, second intent for the vast majority of shave biopsies. I only put stitches in if I'm doing a punch, and usually if the punch is 4 millimeters or larger. Yes, great question. Any other questions, or should we look at a few cases?
I'm curious as to how many people in the audience have experience using those little shave biopsy devices that you can pinch and do that.
Dermablade, yes.
Yeah, the dermablade.
Yeah, so it would be really helpful if you put in the chat whether you use a dermablade or if you have access to a dermatoscope. I know a bunch of the East Georgia folks have just gotten this combination. If you're at a site that does not have a dermatoscope, I would love to change that and help get you one. And yeah, we want to make my site visit as beneficial as possible, right, Dr. Sheldon? Oh, I think you're muted.
Exactly. Yes. Yes.
All right, and good old Raphael is taking notes, so he's going to help me be effective when I come to see all of you.
I looked it up because I was concerned that those little dermablades might be more expensive, but they're really only about $2 a pop. So similar to the cost of a punch biopsy, and I know most people are pretty comfortable using those. Should not add any significant additional cost or anything like that. It's just a matter of getting comfortable with the technique. So
That's right. And so I would be very happy to work on that hands-on, because I will tell you, Dr. Patton, for every punch biopsy I do about 50 shave biopsies because it is so much faster. It is so much easier, and you're so much less likely to get sampling error.
yeah.
All right, you tell me whether to look at cases. I could do this all day because it's my favorite topic, but I also recognize that sometimes echoes stop a few minutes early. Should we?
Well, I think we got time for at least one, and we'll
Okay.
see if it provokes any more questions or comments or anything. And then we can wrap up after that.
All
We
right.
may have to pimp on Raphael a little bit though before it's over with. So
He's just a willing participant because he's part of the medical student WIAMI program, and he's really interested in learning more dermatology, and there just aren't a lot of dermatologists out there. So, all right, this is a 49-year-old phototype 2 man. He came to see me about a month ago because his brother was just diagnosed with melanoma, and his wife was very worried about this dark growth on his flank. And this is what we see clinically. We can see that it is a solitary growth. And then under dermoscopy, this is what we saw. So I know some of you have been playing around with the dermatoscope. So I'm just curious if anyone would be willing to either unmute themselves or put in the chat what you see, what category of growth you think we're in, and should we be worried?
all right, y'all type it in or just open your mic and chime in. What do you see? What are your impressions?
Can you show us the prior picture?
Sure. Oh, let's see. Can I? Yes.
Oh, it's pretty small.
Yeah, it's about 4 millimeters.
So if somebody take a stab, does it look organized or chaotic?
Looks uniform to me.
Yeah, I love it. And
Yes.
does anybody, and maybe this is a perfect tele mentoring and tele partnership. So what about one of the derms? What category of growth do you think this is?
Vascular.
Ah, there's Dr. Davis. Yes. So this is a vascular growth. Absolutely. And the reason this is a cherry angioma is that we see lakes of blood. These are all red lacunae, and this categorizes this growth as vascular. Sometimes with the naked eye alone, it's really hard to know whether something is melanocytic or vascular. But when you see all of these red lakes of blood separated by white septae, this is an angioma. This is a vascular growth. And in fact, it doesn't have any cancerous potential and it isn't at risk of becoming a melanoma. So we can often just reassure patients. But in his case, he was so terribly worried and he said, oh, this rubs when I exercise. I'd like to have it removed anyway, which is reasonable. But in this case, we don't need to achieve breadth and depth and take a large margin for the biopsy. We can still use our dermablade and just kind of slice under that epidermal proliferation. And we can make sure that we have some aluminum chloride or some cautery ready because we know we're in the vascular category and we're going to be cutting right through those blood vessel lakes. So this is a cherry angioma, not a skin cancer. All right. Can you do one more?
Go for it.
Okay. All right. There's a method to this program, by the way, because usually we do benign and malignant in 2 different talks, but it's condensed. So I'm trying to squeeze stuff in. This is a 74-year-old woman. She has this dark growth on her abdomen, and she is terribly worried that this is melanoma. And so in this case, I'm curious if anyone, what your thoughts are. You can put it in the chat. This is the dermoscopy of this growth. Anyone notice anything else in this area? Ah, I see people shaking their heads. So let me look in the chat. Thoughts? So I'm going to give you a clue. Benign things tend to have friends, whereas melanomas tend to be. I see Jennifer shaking her head. What do you guys think this is?
Yeah, Mitchell and Jennifer both put in what I think is going to wind up being the right answer. So
Let's see. Oh, that's right. Awesome. I love it. Good job, Mitchell. Oh, Mitchell, we just worked together on the e-consult stuff too. Thank you very much. Oh, all right. So this is seborrheic keratosis. You're absolutely right. The reason that it's dark, by the way, is because the surface can have oxidization and it can become black, and that really throws people off. Not everything black is a melanocytic proliferation. This is a keratinocytic growth. These are comedole-like openings, well-demarcated border. This is a classic seborrheic keratosis. We recognize that many of our patients over 50 have lots and lots of these, and we don't want to apply the ABCDEs of melanoma to seborrheic keratoses. All right, so good job. That's seborrheic keratosis. Here's another beautiful seborrheic keratosis. And in the interest of time, I'm just going to show you the very last thing to bring it all together. There are 3 very common benign growths: seborrheic keratoses, angiomas, and dermatofibromas. When we get used to looking at those, we get better at seeing the malignant outliers. The one that we haven't hit on yet is the dermatofibroma. Dermatofibromas, by definition, are scar tissue reactions, and they often have a tethering of the scar tissue in with gentle lateral pressure. When you look at them under dermoscopy, they have scar tissue in the center and reactive hyperpigmentation around the edge. And this is true across all phototypes. So all phototypes will have scar tissue in the center and reactive hyperpigmentation. I'm just going to click ahead and show you guys this. And then when we get really good at this, we're able to say, angioma, dermatofibroma, seborrheic keratosis. We filter those out and we say, oh, if it isn't one of those, it might be a disorganized, chaotic growth like this melanoma. And this is the melanoma. This is what we want to get used to recognizing. And then when we see that, we can do the biopsy using this. So with that, I'm going to stop and I'm going to take any questions. I'll leave this on the screen and we can do the cases we didn't get to next time.
There you go. Thank you, Dr. Sieberling. That's incredibly valuable information, and I appreciate the folks who jumped in to put your reputation on the line by actually typing into the chat. Good job, and I think hopefully this will set the stage for more of that kind of exchange of thought and engagement with all our participants. We're going to run up on time here, so I don't see any other questions, but I will ask Dr. Davis or Dr. Buchanan if you have any comments to add before we turn it back over to Rhea.
That was fantastic. Really a great review. I will just say that we, as you get really skilled at this, you can use just the big razor blade instead of the derma blade to do those shaves, which does take a little bit more technique as how much to bend it to get underneath.
Yeah,
So, I mean, I don't know how much those cost. I mean, everything costs money. So,
everything costs money, exactly.
right.
Well, good. Well, thank you. And Dr. Buchanan might still be out on a walk, but
No, I'm just scared he's gonna start screaming. All happy screams though, because he really enjoyed Vinny's presentation. It was wonderful. She hit
Yeah.
all the high points, and I think that it was extremely well done. And
Yeah.
we've already had a few similar consults to what she presented on today that have been sent to me, and so it's very valuable, this lecture, and a lot of takeaways. So thank you.
that's great. And you can see already that the continuing education information has already popped up in the chat. But with that, I'm going to turn it back over to you, Rhea, for closing remarks.
Okay. So, thank you to our speaker, to Dr. Seiberling. That was just great. And thank you to those people who responded in the chat or asked questions as well. So our next session will be on November 3rd, 4 o'clock, and Dr. Seiberling will be talking about psoriasis and scaly rashes. And the CME code is posted here, and you text that to the number. Just a reminder for anyone who's new that in order to get CME, you have to be first registered with the MCG CME office. And if you need help with that, just let us know, or that information will come out in an email tomorrow. So with that, I think we can sign off for today and look forward to Dr. Seiberling's next presentation. And so all guests can sign off now, and a reminder just to our